Okay, good afternoon. Today we have our last lecture in ABG series. We will be talking about respiratory acidosis and respiratory alkalosis. Before we go into respiratory acidosis, let us have some basic concept about our respiratory centers, because most of the etiologies of respiratory acidosis and alkalosis will be focused on respiratory centers. See, we have pons and we have medulla. In pons we have two centers. One is known as pneumotaxic center, which is ventral, and apneustic center, which is dorsal. Both of them combined are known as pontine respiratory group. So this is ventral pneumotaxic center and dorsal apneustic center. Both of them exert influence over medullary respiratory group. Medullary respiratory group have ventral respiratory group and dorsal respiratory group known as VRG and DRG. Combined they are known as medullary MRG, medullary respiratory group. So apneustic center has a positive influence over dorsal respiratory group, whereas pneumotaxic center has a negative influence over your dorsal respiratory group. When you start your respiration by inspiration, this is the dorsal respiratory group which starts firing. We have two sets of muscles in our respiratory system. One is external intercostal and diaphragm, which is positively influenced by dorsal respiratory group, and internal intercostal and accessory muscle, which are positively influenced by ventral respiratory group. When we are breathing normally, effortlessly, so the inspiration is governed by external intercostals and diaphragm. When we are breathing forcefully, or our depth or rate of inspiration increases, then VRG starts firing, and then your internal intercostal and accessory muscles of inspiration comes into play. Otherwise, in normal breathing pattern, only external intercostals and diaphragm are working. Expiration is a passive process. It is a recoil of lung by which your expiration takes place. Inspiration is a process which is started by your medullary respiratory group. Is that clear? Right? So we come to respiratory acidosis. So just for an example, say for example your pH is 7.21, okay, your PCO2 is 58, your HCO3 is 22, your PO2 is 66. So what inference can we make out of this ABG? This is for sure that this is an acidemic pH. 7.21 is a low pH. So we are dealing with acidemia or acidosis. When we see PCO2, it is working in direction opposite to your pH. So it's a respiratory acidosis. Normal PCO2 is 35 to 45. So it is way beyond your normal 45. So this is definitely respiratory acidosis. Now by HCO3 we can find out whether it is compensating or not. So it is low limit of normal. 22 to 26 is normal. So there is no compensation. By PO2 we can find whether the patient is hypoxic or not. So this is definitely hypoxia. We have categories of hypoxia. Say 80 to 100 is normal. 60 to 80 is mildly hypoxic. 40 to 60 is moderately hypoxic, and less than 40 is severe threatening hypoxia. So this patient has respiratory acidosis with mild hypoxemia, right? So we now will try to find out why this patient has respiratory acidosis. So there is a formula, or there is a way of remembering the causes of respiratory acidosis, which is known as 7T formula. 7T. Remember, these centers have to be either stimulated or depressed for having some respiratory problem. So we divide groups into central cause and peripheral cause. So whenever there is an involvement of either the pontine centers or the medullary centers, the cause will be central, and whenever the cause is in the spinal cord, in the neuromuscular junction or in the muscles, it will be peripheral cause. So in central cause we have 70. Say for example, patient had head trauma. Patient had head trauma and there is an injury to your respiratory centers. Your respiratory drive will go away. You will retain CO2. Right? So one of the cause of central respiratory acidosis is trauma to head, giving rise to injury to your medullary or pontine respiratory group centers. Then you have tumors. Any tumor in your posterior fossa can compress your respiratory centers, thereby decreasing the drive of respiration, giving rise to increase in CO2. Stroke. Any posterior circulation stroke in your pons or medulla can affect your respiratory centers and again can give rise to low respiratory drive. Then you have fourth T as encephalitis. Okay, fourth T as encephalitis. You have fifth T as toxin, such as drugs. This is important. We have many drugs which suppresses your respiratory centers. One of them is barbiturates, phenobarbital, which is a very potent respiratory central depressor. Then you have opioids, morphine, oxycodone, codeine. They are your respiratory center depressors. Then you have benzodiazepines. Then you have benzodiazepines such as lorazepam, diazepam. They are your potent respiratory center depressors. So any of these drugs can cause decrease in respiratory drive, thereby resulting into respiratory acidosis. Then you have thyroid dysfunction. TSH is high. Patient has hypothyroidism. So your basal metabolic rate decreases, giving rise to decreased respiratory drive. Then your last T is hypothermia, temperature which is less. The same mechanism that your BMR decreases. Right? So suppose you have a history of trauma and your respiratory acidosis is present, you really can't do anything apart from decreasing the brain edema. You can decrease brain edema by using mannitol, hypertonic saline, or by hyperventilating the patient. Suppose you have tumors, any tumor in your neuroimaging, then you can use osmotic diuresis, plus to reduce the cytotoxic edema you use steroids. Right? If you have a stroke, you treat stroke. Right? If you have encephalitis, so you will have history of fever, you will have history of altered sensorium, you do a LP and you do serologies for your bacterial or viral encephalitis and treat it. For toxins, if you have drugs and patient has taken overdose of barbiturates, for barbiturates you give soda bicarb as a treatment, NaHCO3. For opioids you use naloxone. For benzodiazepine you use flumazenil. So we are not treating respiratory acidosis, mind you, we are treating the cause. So if you have respiratory acidosis, you try to find whether the acidosis is central or peripheral. If you have a central component, you treat it. If you have severe hypothyroidism, the patient is myxedemic, you treat myxedema by levothyroxine and steroids. If you have a core body temperature which is low, you increase the body temperature. So your respiratory acidosis will be reversed. So you are not treating respiratory acidosis by use of soda bicarb. You are going down to your differential of central respiratory acidosis and treating them as such, thereby giving rise to reversal of respiratory acidosis. Now we come to peripheral causes of respiratory acidosis. See, these neurons from your medulla, they go to your spinal cord and innervate your anterior horn cells. They innervate your anterior horn cells. So any anterior horn cell problem, say for example you have amyotrophic lateral sclerosis, ALS, or you have poliomyelitis, which are anterior horn cell disease, will give rise to respiratory acidosis. Right? So historically you will have both UMN and LMN sign. If you have ALS, technically you can't do much about the treatment. If you have polio, you will have ascending flaccid paralysis, which will be acute in onset, and patient may land up in respiratory acidosis if you have cranial nerves, the nerves which are involved for respiration, right? Then spine can be involved per se. If you have transverse myelitis, in transverse myelitis you will have hemisection of the cord. So you will have a motor level, you will have a spinal reflex level, and you will have a sensory level, right? So if the cord compression has occurred above the centers where this nerve is innervating, you will have respiratory acidosis. So say for example you have a cervical cord involvement. So in a cervical cord involvement you will have tetraparesis with your sensory level, plus you will have respiratory acidosis. But if you have a lumbar cord involvement, you will not have respiratory acidosis, right? Now you go to peripheral nerves. From a spinal cord, we go to peripheral nerves. In peripheral nerves, the problem can be autoimmune involvement, such as AIDP. Right? In AIDP or GBS, you will have ascending paralysis with areflexia, right? In neuroimaging, you don't find anything, but in NCV, you will have conduction blocks. You will have demyelination conduction blocks, and in CSF examination, you will have albuminocytological dissociation. How do you treat the Guillain-Barré syndrome? You either use IVIG or you can go for plasma exchange, right? Again, the point is that we are not treating respiratory acidosis, we are treating the cause. So just don't jump around treatment of acidosis. We have to go to the cause of acidosis, why the patient is having respiratory acidosis. From peripheral nerve, you go to neuromuscular junction. In neuromuscular junction, the important point is myasthenia gravis. Again, the autoimmune problem wherein the acetylcholine is unable to bind to nicotinic receptors. There are antibodies against nicotinic receptors. So nicotinic receptors are involved. So you treat neuromuscular junction disorder by giving steroids, right, or some other drugs, and thereby you treat respiratory acidosis. Then you go to muscles. You can have Duchenne's muscular dystrophy in advanced stage. Say the patient of Duchenne's lands up at 20 years of age with profound muscle weakness. So respiratory paralysis is common. So respiratory acidosis is one of the most important manifestation in a moribund Duchenne's patient. You can have patient of polymyositis or dermatomyositis in crisis. Myositis in crisis, wherein patient can land up into profound respiratory acidosis. So again, you treat them with high dose of steroids or some disease modifying drugs. So you tide over the crisis, and then the respiratory acidosis will be taken care of. Now the problem could be in lungs too. Suppose you have an obstruction in your airway. You have a tumor, you have a growth in your airway, or you have a mucus plug, or there is some sort of obstruction. So what will happen to your CO2 excretion? It won't take place. You won't be able to breathe out CO2 much. So you will retain CO2. So any obstruction in airways, so obstruction could be because of chronic obstructive lung disease. It could be because of some intrabronchial growth, some tumors. It can be foreign body. Which is hampering the gas exchange, right? So CO2 is being retained. Suppose you have profound consolidation. This profound consolidation, what it will do, it will decrease your oxygen uptake and it increase your CO2 excretion. So CO2 will be retained. It will decrease your CO2 excretion. So this oxygen, low oxygen, is an important stimulus of your peripheral chemoreceptors. Peripheral chemoreceptors, which are in your carotids and which are in your aorta. So hypoxia is a potent peripheral chemoreceptor stimulator. These peripheral chemoreceptors, they hit your central nervous system respiratory group nuclei, and the drive and depth will increase. So rate as well as depth of respiration increases. So you are now hyperventilating. So initially there would be a component of respiratory alkalosis. Initially you will wash out, right? But the pathology is still there. It can be a consolidation, it can be ARDS, it can be pulmonary embolism, right? So there is some major problem where the gas exchange is hampered. So your low PO2 is a drive for your central nervous system respiratory centers to increase the depth as well as rate of respiration. So you will start breathing more. So there will be a time when you will get fatigued. The moment you get fatigued, this drive, though there, won't be able to sustain your respiration. Then you will end up into respiratory acidosis. You're getting the point? So in early course, you start with alkalosis, but later when you are fatigued, your muscles are fatigued, you land up into respiratory acidosis. Just imagine a patient having angioedema, severe angioedema. So what happens? Your larynx is constricted. Your larynx is constricted, your CO2 won't be able to go out. So patient will land up into respiratory acidosis. Suppose you have put an endotracheal tube for a very long period of time. You have laryngeal edema. You have laryngeal edema. Again, the same pathology. So you have to treat them. How do you treat angioedema? How do you treat laryngeal edema? You use liberal dose of steroids, right? So as you correct the pathology, you treat pulmonary embolism, you treat ARDS, you treat pneumonia, you treat consolidation, right? Your problem will be reversed. So this is how your respiratory acidosis takes place. Now in our case, we had moderate hypoxia. In our hypothetical example, there was moderate hypoxia. Always remember that when the problem is central, hypoxia won't be there. If the problem is in centers in your brain, hypoxia won't be there because your drive is increased. Sorry, drive is decreased, but the exchange of gases is not hampered. Unless and until your respiratory drive is so much less that you are not taking oxygen inside. Otherwise, most of the central respiratory acidotic patient tend to have normoxemia or mild hypoxemia. But if you have problem in your peripheries, right? If you have problem in your peripheries, particularly lung problem, then you have profound moderate to severe hypoxemia with respiratory acidosis, right? So we finish our respiratory acidosis now here, and we will see you in another lecture on respiratory alkalosis.